Hello, this is Stephen-Castro, and I want to do a quick recording on hypertrophic pyloric stenosis. I have done this lecture in the past with the previous class, and I have always consulted my resident pediatric nurse extraordinaire, Dr. Shirley Nichols, and with her help, we kind of put this PowerPoint together for you. Your required readings are going to be in your Pediatric Made Easy book. It's a very simple and quick read, pages 506 to 508. It's just a couple pages. I encourage you to read that, although I pretty much sum up everything in this PowerPoint slide. The definition of pyloric stenosis or hyperplasia, it's basically you have increased mass size of that little pyloric sphincter at the bottom of the stomach. But the increased mass, increase in the muscle, and the kind of clogs the stomach to where it can't empty, so there's a delay in emptying, and then it causes regurgitation of the stomach contents. So it narrows that little pyloric canal because of the increased mass, increased muscle, and it prevents the stomach from emptying, which causes a lot of projectile vomiting and other complications. Again, it causes that obstruction and non-bilious vomiting, which means it's not that yellow bilious vomiting. It's usually their feedings. It's more common in boys, ages between 1 and 6. Also, it's around the incidence, it's about 2 to 4 out of every 1,000 births. More common in preterm infants, and ironically, more cases occur in the firstborn male. Again, the signs and symptoms of pyloric stenosis include that forceful, non-bile looking vomit. It's usually kind of like their feedings. It's unrelated to position of feeding. It doesn't matter if they hold them up, put them on their side. It's just projectile vomiting. As soon as they vomit, they get very, very hungry because they're not getting the nutrition. They're not getting the food. They tend to have some weight loss with that. They get progressively dehydrated, and they may be lethargic because they're not getting the nutrition or the fluids. You'll see decreased urine output, and there may be a positive family history of this as well. On assessment, one of the things you can feel on assessment, on the abdominal assessment, is in the abdomen, there's a little movable hard olive-shaped mass in that upper right quadrant, just along the fundus of the stomach where the pyloric stenosis is. It's because that's that hypertrophied pylorus. It's that little sphincter. It's so hard and round that it feels like a little mass-shaped olive in the right upper quadrant of that stomach. There's this little picture of little baby vomiting. Okay, labs and diagnostic. If there's no mass felt, they may not need to do any further testing. Just do a surgical consult. I'm sorry, if the mass is felt, they just need to just get a surgeon in and have them take a look at it. Excuse me. If there is no mass felt, but does have a supportive history, that's all the other signs and symptoms of pyloric stenosis, they may want to do an ultrasound or an upper GI series, which is the x-rays, or they also may want to check for metabolic alkalosis. Surgery is how to repair the pyloric stenosis. Again, it may take on the day of diagnosis if the little client is stable and hydrated. If not, they may have to give them some IV fluids. If they will typically start on D5 1/4 normal saline. And again, this is probably a little more detailed than what you'll need to know for the exam for sure. Because we like to make sure that they remain hydrated, but they also need a little bit of carbohydrate with that. If they are in alkalosis because of the vomiting, remember we talked about acid base. With vomiting, they lose a lot of acid. They may be in metabolic alkalosis. MPO until surgery, they may need an NG tube to decompress the stomach to keep all the stomach contents out. During surgery, they basically just make a little long incision around that pylorus and kind of dissect it. Basically, it helps open that up so the contents can pass. Nursing care includes monitoring the vital signs, pre-op, post-op, monitors the eyes and nose, pre-op, post-op. Remember with babies, when you're monitoring eyes and nose, you include weighing the diapers as well. You would want to record the amount of vomitus because they have so much vomiting. Daily weight, same time, same scale. Monitor their abdominal status and their cardiovascular status. Babies tend to get dehydrated and they show those signs and symptoms a little bit differently. Typically in adults, you'll see elevated heart rate and low blood pressure, but by the time kids get into near shock or something like that, it's typically they have one of the first signs they have is a delay in the capillary refill. It's not necessarily a blood pressure. They tend to like compensate for quite a long time, but once they get sick, you can definitely see it in their capillary refill. We always want to try to position this after surgery, position the child on the right side to kind of help prevent aspiration of vomitus. It's the way the anatomy of the stomach is. If you kind of look how that is, if we position on the right side, that hopefully that food will help being emptied into the duodenum. Here's just a little picture of the surgery, pre-surgery and post-surgery. You can see where the pyloric, the pylorus is narrow at the top on A and open on the bottom after B, after surgery. Again, after surgery, post-op, we want to start with small amounts of oral electrolyte solution. Some places actually go straight to feedings, but we want to start that as soon within a few hours of surgery. We want to kind of get that going. Make sure they have a pacifier. I want to keep that rooting and sucking ability for the child. Monitor their I's and O's. Keep that incision clean. Typically just warm water and soap. Make sure that, if they're wearing diapers, that they don't get any of the stool or urine on that area. If vomiting occurs more than 5 days post-op, they may have to have radiology do another series of exams to look at that site to make sure there's been no complications. And because of surgery, they just need to monitor for apnea for at least 24 hours. That has to do with the anesthesia. More nursing management, educate the parents, monitor their feedings, teach parents how to monitor for eminence, monitor for apnea if they go home. And we will also be interpreting labs pre-op and post-op, so watching those electrolytes and any other test that they may order. And again, I got most of the information from your book, but I had access to some of the other pediatric books that we've used in the past, as well as UpToDate, which is through Lippincott. They leave a lot of good references on the Lippincott website. If you have any questions, please don't hesitate to ask. Keep in mind, there's only two questions for pyloric stenosis on your exam. So, hope that helps, and happy studying.